Hey, BC here. Welcome to BC Nephro. Thanks for watching. Today I'm going to be talking about my approach to the diagnosis of CKD, chronic kidney disease. Now, I'm not talking about diagnosing that the patient has chronic kidney disease. I'm talking about making an assessment and diagnosing what the underlying cause of chronic kidney disease is, so we can institute appropriate treatment to slow progression or maybe even reverse what's going on. For more information, check out the other videos at this channel and check out bcnephro.com. Link will be in the description below. Now let's get into it. So we're talking about typically a patient who presents with an elevated creatinine and a depressed GFR. The first thing is to do some triage and make sure that there is not something severe emergent going on, so that there's not severe azotemia, uremia, hyperkalemia, acidosis, or fluid overload, something that would require emergent treatment and possibly hospitalization for the institution of urgent dialysis. If this is not the case, the second question is this really chronic? What is chronic? Chronic, as defined by chronic kidney disease, is an abnormal creatinine GFR for at least 3 months. Acute kidney injury is an elevated creatinine or abnormal GFR over days. And subacute kidney injury, also referred to as acute kidney disease, is over weeks to up to 3 months. So how do you know if it's chronic? The main way you know it's chronic is you have a baseline creatinine to compare it to. In some cases, you may not have a baseline creatinine, and in these cases, you need to repeat the labs in a timely manner to make sure that it is chronic and not acute. If there is acute kidney injury with oliguria or rapidly rising creatinine over days, this patient is going to require hospitalization and should be referred for that. If there is a subacute kidney injury over weeks to months and the patient is not severely ill or have any other severe manifestations, then what I typically do is to look to see if there's any transient influences that could have done this. So these typically are medications, other acute illnesses, infectious illnesses, dehydrating illnesses such as diarrhea, decreased oral intake. Look at the medications, get familiar with the medications that can affect creatinine and see if any could be safely held. These include certain blood pressure medications, renin-angiotensin system blockers, diuretics, NSAIDs, fibrates, and if they can be held and the creatinine repeated after the acute illness, after the medications are held, the creatinine may return back to either its baseline or completely to normal. If you've determined that there is chronic kidney disease, we really get to the basics to come to a diagnosis of what the cause is. What are the basics? The basics are the history and physical, the urinalysis, urine studies, and imaging, typically a kidney ultrasound. So first, look at what systemic diseases the patient has that are associated with kidney abnormalities. So these most commonly would be hypertension, diabetes, cardiovascular disease, rheumatologic disease, prostate disease that could cause obstructive uropathy, and malignancy. Assess for these. Sometimes these will already be present. Sometimes you'll make the diagnosis with the kidney disease. As part of this process, you're going to be looking for systemic manifestations of any of these other diseases or other laboratory abnormalities. You're looking for hematologic abnormalities, anemia, thrombocytopenia may point you in a direction, or other metabolic abnormalities such as hypercalcemia, which would point you in a direction of a unifying diagnosis. The next step is to look at the urinalysis, and really you want to find out if there's proteinuria. So the urinalysis is going to show proteinuria, hematuria, and leukocyturia. If the urinalysis is completely negative, there's one diagnostic differential and algorithm, which really includes things like hypertension, nephrosclerosis. Myeloma kidney can present with a bland urinalysis. Certain chronic interstitial nephritis can do this as well. If there is proteinuria along with hematuria and or leukocyturia, you need to be thinking about the possibility of a glomerulonephritis or an interstitial nephritis, and you're going to do the serologic workup based on that. Check out the link to the acute glomerulonephritis evaluation for more specifics on how to evaluate that. Now, if there's proteinuria on the urinalysis, and even if there's not proteinuria on the urinalysis, because the urinalysis just checks for albumin, you're going to want to check, I check both the urine protein to creatinine ratio and the urine albumin to creatinine ratio. Now, albumin is the main form of protein, and in a glomerular disease, the albumin will be 60% of the total protein in the urine. So if you have that ratio and a significant amount of proteinuria, typically a ratio greater than 1,000 milligrams per gram, you're going to want to do a workup for glomerular disease, glomerulopathies, and the link will be to another video and article in the description below about the serologies and possibly renal biopsy to do that evaluation. If the urine albumin is very low and the urine protein is very high, the ratio is less than 60%, then you're going to think about non-glomerular causes of proteinuria, which are tubular proteinuria, so you're going to think about a chronic tubular interstitial disease, or overflow proteinuria, which is what happens with light chains with multiple myeloma. After the basics of history and physical and urinalysis, urine studies, then comes the imaging. So in all cases of chronic kidney disease, I do some sort of imaging. What am I looking for? You may come across something like polycystic kidney disease, even in the absence of a family history. The family history may not be known, or there may be de novo mutations. There can be other congenital kidney diseases that were maybe not as severe and picked up as pediatrics and only diagnosed as an adult. There may be obstructive uropathy that was not diagnosed. You may also find renal asymmetry. So if there's renal asymmetry, I'm thinking about the possibility of renal vascular disease causing decreased perfusion chronically to at least one of the kidneys there. You're also looking for increased echogenicity and atrophy of the kidneys. If these are the case, this most likely suggests that there is chronicity, which you can figure out by the duration of the creatinine elevation. So that's it. That's my approach to evaluation of chronic kidney disease, the specific diagnosis, which I think is important to make an attempt to establish. If you made it this far, thanks for watching. Hit like, subscribe.